It's a very tall order to follow Mangalam as a moderator. I don't have nearly as interesting shoes. And so, I feel very brave being out here, but I can confidently say these two gentlemen have been even more courageous. They've braved Bangalore's traffic. Thank you for making the trek. And Bombay's traffic, exactly. So, they're two Herculean tasks done. I think just before we jump into, the topic at hand, both of you know, value-based care very well, but just for the benefit of everyone in the room, just baselining what we mean by value-based care. Today, when you think about what an insurer pays a hospital for, it is for the number of surgeries done, the number of admissions, the number of tests done. That's volume. When we talk about value-based care or value, we're essentially flipping the script and we're talking about outcomes delivered, so health of the patient, etc. So an analogy you can think about is, today when you take out your Uber or Ola apps, you tend to pay for a taxi ride based on the distance covered. We're instead saying, look, pay for arriving at your destination safely and with comfort, right? So it's a very different sort of paradigm. The concept is not new. Different countries have adopted value-based care in different ways. The US market for decades was a volume-oriented market. They saw costs skyrocketing. And then they said, look, the house is on fire, we can't afford this. So value-based care was a fire extinguisher to really reduce the cost. But the focus was very much on clinical outcomes, right? And continues to be so. When we talk about China, the approach has been very different. The focus there was, as many things in China, top-down, national policy-driven, group patients into disease cohorts, make very aggressive volume-based discounts on drugs, and the focus there is on cost containment, right? Two different philosophies. India is a little differently placed. We've always thrived on frugal innovation, $500 heart surgeries, low-cost stents. We don't currently face the cost pressures that the US and China did, but in the context of the Indian healthcare, what we want to discuss today with these two gentlemen is, what could value-based care look like in the Indian context? Before we jump into the topic, Varun and Viren, we'll just like to get a sense of the pulse of the audience. So if we could put the two questions we have for you up, and if the audience could take out their phones and answer two questions for us, it'll give us a sense of how everyone is thinking about this. The first question is easy. Insurance is growing rapidly. This is your chance to tell Varun, Viren, and the insurance industry what else you'd like to see. Please stick to the options we've provided. Don't ask for spa treatments. Yeah. And the second question is really around incentives, because if we think about healthcare outcomes as being the end goal, everyone in the value chain needs to have aligned incentives. And so we'd like your perspective on who do you think is the mischief maker in the value chain of healthcare today. So we'll give everyone maybe 30 seconds to just take a first pass. I can see people looking up from their phones, so I think we have a critical mass. Can we maybe look at the answers? Interesting. So the biggest gap today in the health insurance sector is preventive tests and diagnostics. Varun, did you know this earlier? Because I know you're thinking about this in a big way. So I'll come to this. But that's interesting. So this room is thinking very differently from maybe what the insurance industry is focusing on today. And what about the next question? Viren, I'll give you a chance to refute this perception that providers today have incentives that are most at odds with effective patient health outcomes. But thanks everyone for giving that perspective. Let me now jump to our two panel speakers. Varun, I'd love for you to maybe start with the patient and insurer perspective. To my mind, when I think about, India, it's not a homogeneous country, right? There is an affluent population. Many of the people in this room would fall within that. They perhaps think a little bit more about wellness and prevention. There's a large mass of the country that's more focused on just coverage and cost. Can you talk about what are the trends you're seeing in health insurance? How does it differ by population strata? Where is prevention on the radar of people today?
Those were interesting pieces, and coincidentally, we had a conversation, and I'll correlate it to the last panel where there's I think Rehan mentioned there's a Scandinavia, there's a Southeast Asia. So we're talking to the Scandinavia right now, and that's why probably the preventive piece comes up. And you're absolutely right that these three segments, roughly broadly, are really catering to very, very different. Some of them at the higher end within Scandinavia, if I were to call it, are even like wanting to access genetic tests and so on and so forth. Probably the big middle is really solving for affordability, much lesser on the preventive, proactive side, but really solving for affordability. And the third, which was referenced to as the sub-Saharan is just somehow access and not dying or not falling into the poverty trap, right? So there are very different solutions. As far as health insurers are concerned, or insurers are concerned, I think one of the challenges that we constantly face is that everyone's catering to all three of these populations, or attempting to. If I can take a very Acco-centric view, we are at least trying to first cater to the so-called Scandinavia, or the upper echelon of the market, where preventive, managing your conditions, or at least being in the so-called Japanese culture of having their annual tests done is critical. But I think from our understanding of value-based healthcare, if I can be a little bit controversial and pessimistic, I think we're far away. And if I can participate in the poll on the second question, who's most at odds, I think there was one option itself missing there. I think it's private equity. The reason I say that is because I have had this opportunity to see some investment memos of hospitals, and the first metric is OPD to IPD conversion. So when you have OPD to IPD conversion, I think as much as the provider is at odd, your 5-year, 8-year cycles and making money is probably the biggest. So I think one option is missing, at least according to me.
Guilty as charged. But Varun, just continuing with that, are insurers today at all thinking about prevention?
I think they are, but but it's very superficial. If I can be candid, at the moment, we've seen some people trying to do wearables and attach your health insurance premiums to wearables and so on and so forth. I think that's a lot of lip service innovation, in my opinion. I think preventive is about rewarding measurable adherence, in some sense, for patients to, if you look at preventive, and I really want to lower health costs in the long run, once a customer buys insurance, essentially the insurer and the patient are roughly on the same side, right? Neither does the patient want to land up in the hospital, nor does the insurer want the patient to. So theoretically, the incentives are aligned. But to get that where the patient/customer starts to align with the insurer in terms of adherence, monitoring, so on and so forth, I think we're a little far away. Some of the challenges, if I may, are also regulatory, if I may say so, which are more insurance regulatory. To give you a sense, one of the products that we're trying to do is for a population which is, let's say, highly diabetic or already has conditions which typically most insurers today, want to rule out. They don't want to provide insurance to these kind of patients. The reason is because the regulations today, for that chronic cohort, India is also slightly socialistic in its regulatory approach. So they'll say, hey, you can't unilaterally cancel a policy. Okay, if I cannot unilaterally cancel a contract, I cannot build an adherence enforced product. to say that if for a chronic patient, I can say, hey, as long as you're on your medication, you're exercising, and you're taking your preventive tests, I'm happy to continue your policy perfectly, so that at least I can manage that chronic risk. Versus taking a socialistic approach, what's happening with insurers right now is they're kicking people out because I can't cancel your contract, I rather not underwrite you. So from a perspective of insurers, building in preventive, I think we're at very early stages. As ACO, we're trying to look at that Scandinavian population and trying to see what can build adherence for them. But I would, if I were to sum it up, today give it like a 2 on 10, maybe lesser.
That's interesting, and that's the baseline for Scandinavia. Viren, I think we have both been called out, you by the audience and me by Varun. But I think it'll be helpful if you can give the room some color on when we see this, because we are investors in healthcare delivery as well. What is the context in which hospitals are operating? If you could talk about there is cost push, there is volume-based reimbursement, there is a dramatic change in insurance penetration. If you can just give some color on how the environment is today for providers.
So for providers, which is hospital operators, doctors, it's an absolute free-for-all. It is scary today if you're a patient. It's scary today if you're an insurer, because it does seem like we're entering a level of ridiculousness that I've not experienced in 20 years of being in this space. And I say this as a participant in the hospital space, as someone who runs many, many hospitals and hires thousands and thousands of doctors. I was having a talk earlier today when I'd come into the city with one clinician who wants to sell his business because he's not able to compete. And I asked him, what are the most ridiculous stories you've heard? And he told me about this one hospital that is very popular with the Scandinavian lot of you, located in South Mumbai, which charged his uncle for an open heart surgery. This is the most common sort of surgery that is done in our group. The doctor's ask was 65 lakh rupees. That's about $80,000, which is pretty much what you'd pay at a top US hospital. And this was all cash, it was all under the table. To put in context, the average cost in our group is 3 lakh rupees. Right? And then he said that his nephew was given a quotation for a tonsillectomy. A tonsillectomy it's a nothing procedure for 5 lakh rupees. And on the one hand, I can be nothing but awed and say, wow, this is amazing, in that this is the best business to be in, where you can throw a stupid number like that and expect the customer to pay. But on the other hand, it is the scariest thing imaginable, even if you're a participant in the space, because that sets a baseline that presupposes every single cost bucket that flows down from it. Hospitals are not price takers in any classic sense. We are intermediaries. We face a bundle of input costs and we're able to pass it on to customers. And the minute a lot of this starts to come in, a reflexivity gets built in. So then this gets baked into the expectations. Every person going to medical school is expecting that much to be paid in salary. Every person making a medicine is going to price it at that much. And society bears more and more of this cost, which is unsustainable. I mean, this is the classic fee-for-service trap that countries like the US have gone down, and that's a path you can never get out of. Now, why this is scary for me as a provider? Not just because of what I expect the regulatory response has to be. This makes our job harder because as an organization, Narayana has always been committed to making things more affordable and to build a scalable model. This is not scalable. This is not what scalable looks like. This is not what an industry should aspire towards. Not necessarily maximizing PE returns, because that is on 5 and 7 year cycles, but maximizing the long-term growth and health of an industry. One that grows the volume of patients treated. Now, Varun mentioned the IPOP conversion. A lot of people talk about the average realization and the ROCEs in this space. The one thing investors have missed out is that in the past 3 years, in every hospital on a same-store basis, the absolute number of patients going in has only grown single digits. It's not that the population growth has slowed. It's not that people are less sick now than they were. They're as sick as they've ever been.
And that's really interesting perspective, Viren. And, if I was to sort of juxtapose that with what a lot of people in the audience said, they're looking for, preventive care. And as we think about the context of value-based care, we're talking about reducing complications, reducing readmissions, long-term outcomes. The basic premise there is that you can actually measure patient health. Are health systems in India today geared up for that? I mean, can you talk about, is it even possible, and what are practical challenges there when you think about sort of long-term patient health?
Well, thank you for the wonderful segue for me to talk about the venture we're starting in value-based care. We have recently started offering insurance. We are the only hospital-owned insurance entity in the country. So the way I see it, I don't see a world in which everyone's healthcare utilization is less in the future than what it was in the past. I think not that people are getting sicker, it's that you access more healthcare. My favorite question to most people when they challenge this view is, I ask them, how many times did your great-grandfather visit a hospital? Usually none. How many times did your grandfather visit a hospital? Once, mostly around the time that person died. How many times did your father visit a hospital? Maybe 2 or 3 times. How many times have you visited the hospital in the past month? Well, maybe 3 months, at least once. So healthcare utilization does go up. Now, is that a bad thing? From an insurance perspective, if you look at what average claim size, average utilization looks like, it's very, very bad. But if you look at healthcare as one of the top 5 buckets of spend, this is to be expected, because healthcare is linked to productivity, healthcare is linked to increased lifespans, it's linked to what a modern society is supposed to look like. When life expectancy moves from 40s to 70s, increased health spend is normal. Now, in that scenario, if you are utilizing more and more of a service that displays very high upfront costs, which is capex, infrastructure, land, medical equipment, and has very large operating leverage and can be utilized much more than what it is now, this is the classic thing where you can convert something that is paid in discrete increments to something that is paid as a subscription. So whether it's your Netflix model or whether it is any sort of model in which the more you scale, the cheaper it is for everyone involved, healthcare can display these characteristics. It doesn't work if you're doing fee-for-service, but it does work if you move to value-based care. So what does that mean? I have a plan to spend, say, 1,000 crores putting up a hospital, a 500-bed hospital somewhere. Today, there's no guarantee what will fill up those beds. There's no knowledge about what sort of infrastructure you need to put in, whether it make it 30% oncology, 50% cardiology. There's no idea of that. But if I were to flip it and say, I will build only the size of infrastructure that's required for a 1 lakh subscriber base in one geographic location. And I know exactly what their profile is. I've done enough preventative tests, and I know enough about the health profile to build according to what the needs exactly of those 100,000 subscribers are. It may not be 500 beds, it may be 300, it may not require 1,000 crores of infrastructure, it may be a lot less than that. And then I can amortize that spend over the lifetime cost of all the subscribers. And then that flips the equation from me charging as much as is possible from every single person, assuming this is a one-off interaction, to one in which I need to retain them for their life. So that's the economic argument behind value-based care. Why I think why it's good for society, why it's good in terms of controlling costs is self-evident. But why is it good for a hospital to get into it is that it aligns our biggest cost bucket with what we expect the revenue model should look like.
And so if we were to fast forward, Viren, let's say, several years in the future, is it that you see for Narayana Health, delivery and insurance is sort of going hand in hand? It is inextricably linked? Is that sort of the way you see this eventually playing out?
In any industry, financing and the delivery of that service or product are hand in hand. Right? The time in which you had to book the Bajaj Chetak when you were born and then you got it maybe when you were 18 is long past us. Now, financing is closely linked to house sales, car sales, and tomorrow insurance will be closely linked to healthcare spend. So the ability for someone to afford and pay for healthcare in smaller increments over a lifetime is directly linked to how much healthcare utilization and how this industry grows.
Got it. Are other providers thinking in the same way as you in terms of taking this integrated view longer term? Or is this a bit unique right now?
No, I mean, it's unique only in terms of a construct. It's not that other healthcare groups have not. I mean, every single large healthcare promoter has at some point gone into insurance because they are sort of linked. And there is tremendous amount of brand affiliation with that. But as I have come to learn, and my respect for Varun and the work he does has grown 100-fold, is that this is very, very hard. It's not easy. Insurance is discretionary, whereas healthcare is immediate and non-discretionary. And it's very hard to convince someone to pay for something when they don't absolutely need it right now.
No, and Varun, maybe good segue to check your take, is the move from counting admissions to actually looking at outcomes, is it even feasible in a country like India? Is value-based care something that you see as, you mentioned we've scratched the tip of the surface right now. We have some subscriptions and some outcome-linked premiums and, sort of early experimentation. But if you could talk about what's your view on how real it is for India and what are some real bottlenecks before this could become something meaningful?
So I think we're at super early stages. One thing I'm quite confident of. Timing, I'm not sure of whether it takes 2 years or 3 or 5 or maybe slightly more. Is this current system that we're in, which Viren mentioned as free for all, is absolutely crazy. And it's sooner or later it's going to bust. In terms of today, we constantly see payer-provider wars, almost like they're at loggerheads, to the point where 2 very eminent insurers were kicked out of a cashless network as recent as about 2-3 weeks ago. I think they've modified and somehow managed a truce. And this is happening constantly. Now, I'm not assigning blame here whether it's the insurer's fault or it's the provider's fault, but at least the kind of bills we see as an insurer, some of them are like, what is this? It just doesn't make any sense, both from a protocol standpoint or how things have been managed. I think today, because of the way...
Sorry to interrupt, do you actually track things like readmissions and recurrence rates?
We do,
and the
but
like?
There's no way to hold today, unfortunately, a provider accountable to say, hey, I'm going to, what's the readmission rate?
Got it.
Also, let's understand this today. If unfortunately, and I'm saying this as a part of the insurance industry, if for a regular customer, he trusts the doctor when he's sick. If the doctor says, ye karna hai, yahan karna hai, so by and large, finally, whenever he's made up his mind, he doesn't trust the insurer. Insurer number 2, right? So care navigation is very difficult for an insurer in the current model, at least that we run today, where I can, let's say, if it's an elective situation, not an emergency, I can say, advise you, say, go to ABC doctor, XYZ provider, I can manage the cost, I can ensure readmission does not happen, there's some, proactive care that will happen post-surgery, and so on and so forth, and there's some advisory that the customer is willing to take from the insurer. That's not the case at all. We find out that the customer is going to be, the insurance industry largely, I would say, finds out today that the customer is getting admitted when he's already at the hospital. There is no navigation possible. Correlating to that point is, so when the demand flow to the provider is agnostic of the payer, the provider is not going to listen to you, because it's not like your insurance product is giving me more flow. There's some financial, sort of gross billing volume level discount that you can theoretically argue for, but really it's who controls the demand. If the doctor and the hospital are controlling the demand, there's no way that the insurer can enforce some protocol, some outcome, some readmission, and so on and so forth. But the point that I was trying to make is, but this free-for-all situation which is leading us there, I think has a certain timeline. And it's starting to bust, because right now, whether the government's also sort of woken up, the insurance guys are lobbying, hey, we need a regulator for hospitals, or what do we need to do to bring the cost down? Somewhere or the other, I do believe, either just purely economically or with some government intervention, or somewhere or the other, something will give. And while groups like Narayan are probably proactively solving it and trying to, say, hey, how do we access affordability, capex, subscription costs, bring the financing model together, not everyone is probably going to be able to take that leap. We've had Manipal, we've had Apollo in the past, be part of this, but somewhere the ecosystem, like we said, will need to start collaborating. And the unit of the contract would start changing. Now, I think the unit of the contract will probably start changing in the bigger cities where the growth will come down, some activism will start to happen, or some, as the wars that between payers and providers we are seeing, somewhere something will give, and maybe in a silo you'll see some insurers and some providers starting to align on saying, hey, let's change the unit of the contract from per admission into per procedure into saying, hey, what's your readmission rate? There'll be a readmission rate linked bonus. There'll be some protocols for at least high variance situations that are started. I don't think we'll be able to get to, my sense is we won't be able to get to full blown value based care, but very quickly, but we will start to get to a point where at least the unit of the contract can start changing to some level of outcome management, to say, hey, readmission to the protocols need to be followed at least for standard stuff and so on and so forth. I think that's what, but it's tough for me to say, or anyone rather, I would hazard a guess and say it's tough for anyone to say whether this starts happening in what pockets in how much time. But I do believe that the pressure is building on the system, and it will soon happen.
And I guess the question for both of you, do you see insurers and providers getting together and sharing risk, perhaps in a more top-down manner, tier one, more affluent first and followed thereafter, or do you see it perhaps playing out in certain disease areas, which are higher cost and higher prevalence, like cardiac, diabetes, oncology, and the like? I mean, any thoughts on, what could be sort of an initial evolution to kick this off?
In 2014, I made my first approaches to it was a very long road till we decided it's better for us to become an insurance company. But in 2014, I made my first approach to, at that time, the group that had the largest book of health insurance at that time. And I'd come to them with a proposal where we would work on something on cardiac packages, where we would offer them really good rates, much lesser than what they were paying in the market at the time, and we would manage the patients proactively, and we would help reduce the overall claim on their book. Just from a health plan, because cardiac back then and even today is still the largest amount of claim on the tertiary side. The only thing we asked in return was some element of steerage, where they said, proactively, please tell us who your highest risk patients are, share their medical information with us, and we will get in touch with them and do all the things that are in advance. And should the cardiac event happen, move them in our direction. And we found out they had no ability to do that. They don't. They don't know their customer. They don't know anything about their health status. They have no ability to steer either way. Then I tried it with another insurer, maybe 4 years later, and we wasted 2 years talking with them. Then it made me realize that at least, not all, but most health insurance companies run like a very badly functioning credit card. It's just the payment mechanism. It focuses on distribution, but they focus entirely on the claims and payment aspect of it, not on anything more proactive. So in terms of when you ask, can hospitals and health insurance companies work more proactively, 100% they can. I'm not saying they can't. But the incentives are not aligned that way, and I understand why as well. Because as we're beginning to learn, selling is the hardest thing in the world. And if all my job depended on selling, I'd have no time to worry about what the hospitals are doing on their side and what the patients are doing, because those claims come much later. Now, there is a way forward though. Globally, you are seeing large insurance companies, whether it's United Health or Bupa or Hapvida in Brazil, there are insurance companies getting into some elements of clinical management, not running hospitals, but running clinics and running, United, for example, hires the largest number of physicians in the US. So that'll happen on that side. Meanwhile, hospitals also will start looking more into OPD insurance or just insurance products. And so that convergence requires each one to take a little bit of a load from the other side, and then I think you'd get something closer to that. But one where there's perfect symmetry in the opposing incentives. I pay you, I lose that money. That it simply can't work.
I'll just add to this on the insurer side, okay, for a sec, apart from maybe the asymmetry. Today, I think while we're talking on the value-based care and how do you align provider-payer incentives, I think one thing is much top of the funnel, and I'll blame myself, the entire industry, the insurance industry. How much do we spend on acquiring versus managing healthcare? The room, some people are from insurance, they would know. Understanding the risk profile of a customer, and therefore onboarding them to the right product plan whatever it is with the right maybe frameworks, then tracking their health, and then hopefully doing some steerage. Nobody's doing any of this. Okay. All we're saying is I'll offer you 40% commission, I'll give you 50% commission, I'll give you 75% commission. That's all there is to it. And the best part is we have worsened as an industry in terms of understanding the health profile of the customer that I'm onboarding, because the only way to get a distributor to sell my product, if an agent or a bank or whoever it is, to offer more non-medical limits for underwriting. So it's almost like, hey, you will work with me, you will distribute more of my product by either I can offer you as an insurer only two things to my distributor, to my agent or my bank or broker or whoever is selling it. Essentially, I offer you more money, which is more commission, and I lower the onboarding friction by taking lesser risk profiling by saying up to 20 lakhs no test, up to 10 lakhs no test, up to certain age no test, which is basically your onboarding risk blind and you're paying for it. Not blind maybe, but partially blind to some degree. Now, so much effort is just managing this chaos, and then on top of it, building mitigants inside the product for risk management. 3 years this is not covered, 2 years that is not covered, 5 years this is not covered. If you build a lot of, there's no risk mitigation or understanding of the risk that's coming in, because you're saying non-medical limits keep going higher and higher to attract distribution. So what you do is you end up building mitigation inside the product, complicate the product. You complicate the product for the customer, you complicate the product for the provider. And then something is paid, something is unpaid, apart from the provider doing their free-for-all billing. It's just utter chaos, right, across the board. So I think as much as there is this side to be solved of aligning payer-provider incentives in cohorts or in certain, maybe standard surgeries or whatever it is, I think the insurance industry also needs to take a hard look at themselves as saying, where are we spending our money? If the customer gives me $100 of premium and I give out $50 in acquisition and operating costs and complicate my life, then it's just bad on both sides.
Yeah, I mean, I think India is known in that phase of land grab to deteriorate economics, and it seems like this is playing out even in insurance. And I'd actually want to come back to this point, Varun, but again, maybe a question for both of you. We've spoken a lot about sort of a little bit the affluent Scandinavia equivalent population. The 700 odd million people who are on Ayushman Bharat today, today it is very much volume oriented. Do you see a future where, policy might also evolve towards focusing and, of course, political equity is derived more on coverage numbers than necessarily on outcomes, but do you see a world where even the government might think about outcomes more seriously? And specifically, we hear a lot about, ABDM, which, for the audience is driving interoperability in health records, right, across systems. And I think that foundational data layer has been a real challenge in other countries to sort of drive the adoption of value-based care. We might have the advantage of a standard coming into the country. I would just love to get both your perspectives on, do you see any time in the foreseeable near future or mid-term future, Ayushman Bharat thinking about such a direction and ABDM playing a role in accelerating it even on the private side?
So today, the Ayushman Bharat, what the government spends, their allocation, Ayushman Bharat is a fee-for-service thing that pays very little for the surgeries that you do. But the total outlay is less than the revenue of the largest hospital group in the country. So the thing about 70% coverage, it's simply physically not possible for it. So there's huge amounts of unpaid bills. But regardless, this is the wrong way. This is the way of Medicare. This is the way of most countries going down a dark path where you pay for surgery. You pay for something, you're going to get more of that thing. A perfect system, if they wanted to create a value-based system, was one in which you took away the entire private sector participation in Ayushman Bharat and you just allowed the government hospitals, which by themselves have all the infrastructure that's required, they just lack working capital. And you said, let the government hospitals bid for Ayushman patients. So that supports their working capital and that keeps the public money within the public purse. Unlike right now where they're spending on both sides. They're spending to keep non-functioning government hospitals afloat and they're spending again to funnel money to the private sector where a huge amount of it is eaten up in fraud. So that's a massive incentive problem. The ABDM part, I think,
Yeah, I think the the good actor in the private sector on Ayushman Bharat doesn't get enough money and doesn't get it on time, and the bad actor gets it through fraud. So it's pretty much complicated there. So it's again, if I may say so, there's probably not enough second order thinking versus sloganeering, if I may call it out, at least from my perspective. I think ABDM and the National Digital Health Mission and the consent-based, I think that will help to at least get transparency and data a lot more clearly. We've been, however, hearing about it for some time now. I don't know how many people in the room have an Abha ID, or a health ID. So starting with that, I think the adoption of that, then the entire stakeholder ecosystem. Right now, you need an Abha ID to get treatment in a government hospital. It's not mandatory anywhere else as yet. So if you were to go to AIMS today, you cannot get treatment without a Abha ID, which is an equivalent of a Aadhaar card, but for health, in some sense. This has to, the way it's supposedly going to work is that clinics to small diagnostic centers to pharmacies to hospitals to insurers all will work with your Abha ID to be able to connect. So if you need to get a diagnostic test done, you will have to quote your Abha ID, and therefore all your electronic records can move from doctor to clinician to diagnostic to hospital to insurer seamlessly, and this can bring longitudinal data of what's really happening. One of the other problems with insurers tactically is that I underwrite somebody at 35 and he comes to me at 45 when he has a claim. In between what happened to that guy, I have no way of knowing unless he actually updates me or I'm somehow able to push a preventive test. This is like a typical, your CKYC consent-based framework. He clicks a button and I can retrieve whatever OPD services that he's doing and build that longitudinal data. The promise is great. We've started to see some implementation. Private sector adoption, when do they make it mandatory? Today, I don't think a lot of private sector hospitals systems are there. HIMS systems in India are fragmented like nothing else. So lots of systemic changes to happen. I think it'll be really helpful as an infrastructural layer, but my sense from the speed at which it's going, it's probably 4-5 years away before it starts to become a part of life. And then how does the ecosystem unfold and what kind of models can we build? Can value-based care be helped? Can more preventive monitoring, more continuous monitoring happen? On top of that, earliest I see something happening is probably 3 to 5 years from now. That's if it continues with the current momentum, because it's been slow.
Got it. And Varun touched upon how NH is thinking about a more integrated approach towards delivery and financing and global analogs of insurers getting into some elements of at least primary care. I don't know, Varun, if you'd like to talk about how ACCO is thinking about this. I know you've given it some thought around diagnostics and the role it could play from an insurer's lens. Would love to get your take on that.
Yeah, it's an early experiment at our end. And Viren already spoke about it. Like I think selling insurance is hard. Running a hospital is hard. Doing both is very hard. And therefore, at least the view that we formed is that we're probably never going to be like good at running a hospital. That's not our core skill set. We don't know how to do it. It's a whole different ecosystem, right? But what we can probably attempt for the Scandinavia to start with, and then hopefully a little larger, because at least there is an ability to spend. There's an ability to say, hey, I want the preventive. I want, I want a few things. Is to start figuring out how do we get into a little bit of their non-acute, episodic life after we've underwritten the insurance for them. We want to be able to monitor our customers over a slightly longer period. And for that, the best place to start is not when something acute has occurred, because when something acute has occurred, you're not listening to ACCO, you're not listening to ICICI, you're listening to your doctor. But you may be, if I provide you enough value, ease, convenience, high quality preventive, a non-hospital experience to preventive and primary and diagnostics, which is today, one of the things that we've seen is that for most of us, we've started skipping a clinic, right? Like OPD is equal to a hospital, like at least in the top tier population. We end up going to even for tests, unless it's some preventive tests, a package test which my employer may have enrolled me somewhere, I'll still end up largely going to a hospital to get a test done. I think there's an opportunity there. We believe that a lot of people who are not sick or just doing preventive or episodic care probably could work well with a high quality non-hospital, non-sick experience to this. So at ACO, we're thinking about how do we build this, digital plus maybe physical clinic with diagnostics and so on and so forth for our customers as a test to see, hey, that's where the longitudinal interaction on health can start. That's when probably steerage can happen. It's tough. Many people have tried it, but I think what we're seeing, like we saw in this poll and what we're seeing from and hearing from our customers constantly is, our customer today who comes online and tries to buy, because we have a largely direct-to-consumer model, the average cover being bought, 40% of them are buying a crore. 40% of them are buying a crore because they just don't trust what the bills could be. And they're willing to pay more for better convenience, better services. So that's the edge. So we're looking at probably starting it off in Bangalore in some time as an experiment. Let's
So this is beyond eligibility screening and the like. You're essentially trying to keep them out of hospital through this endeavor.
It's tough to say. Any of these models, I think from what impact they will have on our underwriting payback period of saying, hey, did that guy actually get out of hospital? Before we get to visualize a cohort and actually see that data, it's probably going to be 5 years before you can figure out anything. What we are essentially trying is, and that's the long pole in this model, right? Like the ability for an insurer to invest in navigation, steerability, monitoring their customers' progression of health over a period of time is because the quantification of that is very hard for half a decade or more. Because you take a cohort, you start working with them, they age, you see what's happening, and so on and so forth. So I think the first thing that we would keep the goal much smaller is what I'd say. The goal for us is to try and probably look at, hey, can I offer you convenience? Can I offer you get in the habit of a preventive test that you're already spending on? Do you trust me enough to talk to me at least for an elective surgery? I'm not saying I'll create better outcomes, but do you trust me to talk to me? If you can talk to me and I can get some steerage going with a 3 lakh cardiac surgery versus a 65 lakh cardiac surgery, that's battle won enough. Even if long term we are actually able to impact health outcomes or not, that'll probably take half a decade to figure out.
Got it. No, that's fantastic. I think we have one more poll for the audience before we open up for questions. I think we'd just like to see how the audience has, what have they gleaned from, so could we put the last poll up, please? What they've gleaned from this discussion. So 10 years from now, when I will definitely be a patient of your institution and a buyer of your policy, what will India's healthcare be known for? And we've given you a couple of options. Let's take 30 seconds and see how the audience sees this.
While they're answering, the data from Discovery Health in South Africa on what pushing people on healthy habits and doing underwriting is a 10 to 15% difference in claims. So that's what they claim is the difference. 10 to 15, it's not bad, yeah.
Got it.
Yeah, so I'll bring it back to, your private equity hold period has to be 15 years to figure out that model. So please double your investment horizon and these models will come up.
Our Excel sheets are going to become far more complicated. Can we also put up the results on the screen? I think Varun and Viren, the audience has completely bought into your thought process. Clearly a very pragmatic group, and the 200 odd people here believe it will be dual track. That's exciting. That means that at least Scandinavia has a chance of focusing on health outcomes. Everyone else will still solve for coverage and affordability. We can open up for some questions now for Varun and Viren. Yeah, please. Couple of questions up front.
Hi, can you hear me?
Yeah, please go ahead.
Yeah, hi Viren, hi Varun. This is Sohit from Briefcase. Just to take up the point on Ayushman Bharat Digital Mission, and I guess both of you knew that was coming from me. So we've been working very closely on Ayushman Bharat Digital Mission. Varun, you're right to say none of us here will have an ABHA ID, but for the benefit of people in segments, ABDM has become very big. We are a very small organization, yet in the last 3 years, we've added 4 crore patients or 4 crore users on our platform solely on the back of Ayushman Bharat Digital Mission. So also it's not, it's the way Varun mentioned, it seems quasi-mandatory in AIIMS and other public hospitals, but it's actually on the back of a very simple use case like Digi Yatra for airports. So the question or the request to both Varun and Viren is, and incidentally, I think both of their organizations are already plugged into the stack. There is generally, we've seen, I don't want to use a very harsh word, but there is a lack of intent we've seen from private sector players. Maybe as Varun mentioned, it's so far out, or at least their belief is it's so far out. But generally, we've seen that some of the largest hospitals are onto the stack. 2 of the largest diagnostic chains or path lab chains are on the stack, but generally we've not seen any kind of acceptance or adoption from their side. So I think the request is slight more amount of willingness to look at it. The National Health Claims Exchange has already got built on top of this stack, and I'm sure that kind of eases the conversation between providers and payers. So just any reaction from either of them to that. We've heard the timelines that Varun mentioned, but anything further on the stack, because at least fundamentally we believe that's going to be a game changer as far as healthcare and insurance is concerned in the country.
Yeah, I'll probably, see, some of these things I think which are infrastructural for the country, you cannot, this is my personal opinion, could be totally wrong. You just need to force it down everyone's throat. That's the only way it's going to happen. Saying that it will be illegal to conduct a medical test or provide medicine without an ABHA ID, and you need to have that audit. You just have to do it. Like you ban cash, do it. The minute you do it, I think there will be some painful 6 months, 3, 4, 5 months transition time, and suddenly this whole room will be aware, and everybody will be aware, and it can happen. I personally don't know what's stopping it, because the technology infrastructure by IndiaHM, and Sohit, you're better aware than all of us, you've been at it for a fairly long time, has been there. It's all there. Right now, there's nothing that needs to be built. Government hospitals are already using it. Some of us on the private side have plugged into that ecosystem. It's there. So somebody just needs to push it down, and we could probably leapfrog into an EMR world within 2-3 years, and everything will be available. Yes, there'll be some transition, some systems breaking down, some issues happening, but that's how UPI happened. That's how a bunch of things happened, right? So I don't know there's today no reward or consequence of using it or not using it. So it's just like happening at its own pace.
I know we're slightly over time, but maybe we could take a question, one more, please.
Yeah, I had this curiosity question for Viren. You spoke about the vertical integration strategy you're considering, a pay-wider model, like a Kaiser, I suppose. How are you thinking about networks? Because it's the downside of a Kaiser model, it's a narrow network, whereas like a Blues would probably be a franchise model, but then you have a broad network. How are you thinking about it?
You'll have to try both. Even Kaiser does not prevent you from going to UCSF or Stanford Hospital or any of those if you're buying their plan in Northern California. It's just more inconvenient for you. So we have a narrow network plan. The lowest cost plan is heavily NH centric, but the ones where you're paying 30,000 rupees for a family of 4, which offers much more coverage and OPD benefits, there is a network we've created that includes Fortis, HCG, Apollo, and all of them. So it's just patients need to understand what they're buying. If they're buying just insurance, then you can go anywhere else. But for us, we're trying to offer them the promise of health, the idea that you can live till you're 100 years old, or you can run marathons into your 80s. And for that, we stress a lot more on the outpatient benefits and the preventative aspect. So it's a lot harder sell, but we think the cohort of people that are more interested in this will keep increasing. And then it doesn't matter, because how often in your life do you expect to end up hospitalized in one of our hospitals? Never. The thing you care more about is waking up every day and being healthy.
I know there are a few more questions, but we can maybe take them over a tea break. I know we're out of time. Varun, Viren, thank you so much. Amazing perspectives. Thank you.